or... Okay, so I'm just going to recap because I just got the camcorder to work. So we just know that, just know that diffusion, osmosis, filtration, diffusion goes from high concentration to low. Osmosis starts out as low concentration, absorbs or whatever, it gets up to a higher concentration. And then filtration is selective, lets things in and out, and sometimes if it doesn't, you have to use osmotic pressure to push it through into the system, okay? So, I got this working now. So now we're going to go over half-lives. Does anybody remember reading about half-life? It always confused me when I was starting out as a new nurse. Because I was like, I'm sick of pill. I don't know what's going to do. I don't care what that means. Half-life is kind of the time, it's kind of important from a nurse's standpoint because it tells us how long basically we have until that medicine takes effect, okay, or that the effect wears off, right? Because half-life is basically the amount of time it takes for the body to remove half of that drug from the body. So let's say I gave pain medicine, and the half-life is 1 hour. So what time or how long of a time would I have before I start seeing symptoms of pain return to my patient?
30 minutes? No. It takes the body.
It takes an hour to
For an hour.
About 30 minutes.
No, 4 hours. Like 4 hours.
Let me start. 2 hours? Let me find it over here.
It depends, right?
It does depend, but it wasn't a trick question.
Oh, it takes. When you get something for 30 minutes, I would say an hour and 30 minutes.
Where did you come up with an hour and 30?
It's because you have to, it takes time
I'm just
for
not
the
understanding.
drug to absorb, and then it takes the body a time to digest it as well. So I was like 30 minutes to absorb and an hour to digest.
But when would they start seeing pain again?
Yeah, that's the question.
Oh, you want to know when they're going to
When
get
is it going to return?
Oh, okay.
So, well, let's start over. So, the amount of time it takes the body to remove 50% of the drug from the body. So, let's say I gave it at 12 o'clock. All right? And the half-life, it was given at 12 o'clock. So, in my drug cards, or in my book, I look up in the half-life for Demerol, let's say, is 30 minutes, okay, the half-life. So that means I give this medicine at 12 o'clock, and I know that in 30 minutes, yeah, it's going to start wearing off. Right.
So it depends on the drug, right?
Depends on the drug, but it's just the half-life of each drug. Some drugs are extended release and stay in the system longer, and some, that's why we need to know the half-life.
So that's why pain meds are given Q4 instead of, okay.
Because
They
have a shorter half-life.
Okay,
Got it.
4 to 6.
Okay?
Yeah.
So just know the half-life is important because, let's say pain medicine, we know nobody wants to be in pain, but what if this was a drug that kept their heart beating regularly? And I know that it's going to wear off quickly. Isn't that kind of important that I need to go back in there and check on them?
Yes.
I need to know what time to expect a change in their status. So when we give something like that, we need to always know what the half-life is on your drug.
So does the half-life, does that mean the pain starts wearing off in 30 minutes?
Yeah, the effect is not as effective.
So do you have to wait for an hour before you give them more? Or
You have
can
to
you
wait
for
whatever
30
the order
minutes?
is.
Yeah, let's say the order is, and that's not usually long, it's going to be longer. It's just, I was trying to make it easy. If the order was for every 4 hours, PRN, meaning as needed, you would only be able legally to give it every 4
So
hours.
would the half-life be 2 hours?
It depends on the drug. It's not by the order. The half-life is not by the order, it's by the drug, the chemical compound of the drug.
30 minutes, they have to last through the whole 4 hours.
Yeah. And if it was 30 minutes, they would give them a different time because it's not holding them. But
But each drug has a different half-life.
yes, that was just an example. Probably not a good one. Okay, so helps explain the dose dose, frequency, and duration. So like she said, if it's something that I know is going to wear off quickly, it has a very short half-life. Some drugs have a half-life of 8 to 10 hours, right? I mean, then I know that's only a one time a day needed kind of drug, right? Some are extended release. That's ERs, extended release, and they're good for 24 hours. That's why you only take them once every 24 hours. And that's because it lasts. It takes that long to digest, absorb, diffuse, all that. Okay, so it's important to know the half-life because you need to know what, be ready and be on top of it. Like, okay, I know it's time for this to be wearing off. I need to be right here waiting on vital signs. Or watching the respirations or pulse or whatever you do. Okay? Alright, so the desired action is what? What you want to happen, right. And so this was in your book on page 38. Okay? So know all those because these are kind of like the vocabulary words. It's the terminology that you're going to have to learn. Okay? Desired effect is just what I'm wanting that drug to do. So, for instance, pain medicine, Demerol, what's the desired effect? To relieve the pain. Alright, and then, this is what we were talking about on our quiz this morning, adverse reactions or side effects. Side effect is just a mild but annoying response. It's something it's an irritant, but it's not going to kill you, right? So side effects are simple. Simple, little, mild, annoying responses to that medicine. Okay, so let's say we gave Demerol. The desired effect is to relieve pain. One of the side effects is constipation. Okay, will constipation kill you? No. But is it annoying? Yes. Okay. Then there's the adverse effect. An adverse effect is severe. It's more severe. It causes way more problems that could harm our patient. And so we're a little bit more worried about those, right? Because if we give them a medicine and, it's going to harm them, we're just making their whole situation worse. So we don't want that. So we always kind of look through, especially if it's a new order for a patient, they've never taken that before, always look through the adverse effects and say, hey, this says, this causes heart palpitations. You already have an irregular heart rate. I may not want to give you this, Okay? And so, like I said, side effects are simple. Adverse are a little more severe and more complicated and can cause more harm. So like somebody who has a stomach ulcer, do we want to give them an aspirin, which we know causes bleeding? No. So that would be a little more adverse. Okay? And then there's the idiosyncratic response. It's like the really rare 1 in a million weird thing that could happen. All these people have been tested and taken this drug. They, served its purpose in the labs. Everybody was safe. Nobody had this reaction except out of, let's say, 1,000, one person had this weird rash come up. That would be the idiosyncratic thing. Okay, it's a unique, very unpredictable reaction. Sometimes, nothing. There was nothing that ever showed up in the test or anybody that's taken it because we're always supposed to report any kind of weird side effects to the companies. That way they keep up with it. So an idiosyncratic is just that really strange, unique, nobody ever saw that coming reaction. Okay? Alright? So like in the example the book gives is blood in the urine from taking aspirin. That is very, very, very rare. But it is an idiosyncratic thing because if the blood is thinned out so much by the aspirin that they're peeing blood, that's something nobody saw coming. Alright? And then paradoxical reaction, paradoxical. Those are the ones that are opposite of what should be expected. So let's say my response, I've given you Demerol, my desired effect is for it to relieve pain, but what is it then put her, sedate her? But the paradoxical is that it stimulated her, made her even more excited and hyper, and now she's wide awake. It's the opposite. That's not what I wanted. And then if you're hypersensitive or allergic, those are things that are like a reaction. Your body sees that medication as something that is not part of its body normally. So that is not supposed to be in here, and it starts attacking it and attacks your body, and that's when you see the flare-up of the hives or the rashes of these people that get real itchy from taking a medicine. That's an allergic reaction where they're sensitive to it. And then, of course, the anaphylactic part of that is they're so severely allergic that it stops their breathing. That's the really, really dangerous one. Okay. So does everybody understand that terminology? It's on page 38. Just kind of get those in your head straight because we're going to build on those later. Bioequivalence is just like when the patent ends. Let's say this company made this drug. Oh, we love it. Everybody loves it. We've used it for 17 years, but now our patents run out. So then other companies can pick it up and use it as a generic. Okay, and sometimes they're exactly identical chemically. Like that company, it did change the recipe. So the medicine that was a trade that's now generic, it's the exact duplicate. Sometimes some companies like to cut corners and they'll change the recipe or tweak it just a little. And that's when you cause problems for patients who have been taking this one all this time, their body's used to it, and now we're giving them the generic, but it might be just a little different, and so their body says, ugh, I don't like that, and it has a reaction, okay? Or doesn't give them the desired effect. So that's just kind of what that is, and it goes into that in your book. Just so that's why it's really important. That's why some patients will not take generic. Like, if they're lucky enough that their insurance pays for all trade names, which most don't now, but if they are that lucky, they're scared to take the generic because they're afraid that's going to throw their body off. Because sometimes they are just a little bit different. Okay. And so then you've got these little old people who take a cupful of medicine every morning, right? It's just basically a chemical cocktail because every med is a different chemical compound. Taken separately, most of the time they're safe, but when you have multiple chemicals and taken at one time, that's going to overwhelm the body. The body doesn't know what to do with it, and so sometimes they interact. There's some that aren't safe to take together, okay? Because now you've completely changed up your recipe. And so the body is overwhelmed, can't handle it, and they may interact and can cause problems. Okay. There's some meds that you can give that the interaction is not dangerous. There are some that are severe, and you'll learn more about those as you go along. There's some that just cannot mix. They will actually crystallize if you draw them up in a syringe. They will crystallize and turn into cement in the syringe. And so you learn real quick which ones you can't mix anything with. Okay. Alright, food interactions. We know that there's so many things, like it said in your drug cards, like it talked about teaching with diet. Why do you think that's a big deal?
Because it can interact with the way the drug works.
What's the point of taking a pill and then going and eating something that's going to block that effect? It's going to, let's say I'm taking, a blood thinner. I'm taking Coumadin, which now they've come out with a different kind of blood thinner that is irrelevant, but because my dad had to tell me that. He was on this now. He could eat whatever he wanted. You have to correct me. Alright, so this is our cell, and normally, here's the receptor sites, plug-ins, and normally my dad would take Coumadin, which is a blood thinner. The Coumadin would come along, connect with each receptor site, and go into the cell, telling it to thin the blood, all this kind of stuff, right? That's the desired effect. But when you eat green leafy vegetables, like spinach, kale, things like that, that have something in them, that vitamin K, that interacts with the Coumadin. So here he was eating a spinach salad every day, vitamin K, and it was floating along, coming through. And what it would do, it would beat the Coumadin to the receptor sites, right? So it was blocking the receptor sites so that his Coumadin, his blood thinner that he needed, wouldn't go in. It was like, sorry, can't get in there. There's already that vitamin K blocking me. And so then his blood got too thick, right? So that's why food interactions and drug interactions matter. Because if you tell them, here, you need to take this blood thinner every day, same time, same channel. Okay. But then you don't tell them, hey, you can't eat green leafy vegetables that have vitamin K in it, or it blocks it and your blood thinner won't work. If you don't tell them that, how do they know? They don't. So you have to go through and tell them about foods that they can and can't eat with every kind of med. You know, most
can't eat grapefruit before.
You know why? Did I tell you why?
No.
So you gonna look it up and tell us?
Yes.
Okay.
I know because I took care of it.
It's the acid, I think, in them, and it blocks their insulin absorption or something like that. But anyway, so food interactions are a big deal. And you'll learn when we get to chapter 19 in your book about nutrition. You do a lot of teaching about foods because it interacts with the body's function and the meds. Alcohol interactions, we already know that you can't take meds with alcohol. Because what is alcohol? It's a sedative, right? It sedates us. That's why we sleep so good. Alright, it's a sedative. ETOH is the abbreviation for alcohol. Alright? If y'all don't know that yet. ETOH, so I'll probably write it like that. It's a sedative. Now, if I'm already a 6-pack in, and I just got this nagging back pain, and I go to the doctor's office and they give me some morphine, which is a sedative, and I take not one but two, what's that going to do to my level of consciousness?
It's gonna knock you out.
I am going to be sedated severely. Now, when, like I said, when the computer brain slows down, what does the rest of the body do? It slows down. So my body's going to lay down and go to sleep, pass out. My respirations are going to do what? Become very shallow and possibly what? Stop. Yeah. So alcohol interactions with most drugs, that's why we say no alcohol with any of them, because we never know what it's going to do, but especially with sedatives. If you're already sedated from ETOH, you don't need more pain meds or something that's going to be a CNS. Yeah, you don't need another 6 pack. You just need to go sit somewhere. With a heat pad or an ice pack. Alright, and then drug and lab tests. You'll learn on this along the way too. When we do certain meds, you have to check their levels, like she was talking about, to make sure that they're therapeutic. Oops. That we don't have overdose or not enough. So, like Coumadin's another example. Every month they have to go in and get their blood checked to see if it's too thin, they'll hold their pill for a couple of days, or if it's too thick, they give them an extra dose, right? Same with that. So they'll be doing lots of lab and values on different kind of drugs to make sure that you're therapeutic, meaning you're right where you need to be, that the med's working, it's giving you the desired effect. Okay? Alright, any questions on that chapter? On page 40 and 41, there's a big chart, well, I guess 42 too, on most of your meds and what the side effects are, like with food and stuff. So that might be something interesting to go over when you're doing your teaching plan. Don't forget about this area. You can go here and that'll tell you exactly what you need to watch for. Yep. I thought I saw the one about the diabetics in here.
I did.
It was hypoglycemic, I think. I can't remember what I read.
It's in this one because I seen something like the grapefruit last night.
I remember. Look at that. For anticoagulants, for Coumadin, there's over 707 drugs that are known to interact with that. Why in the world? And every little patient is on Coumadin, right?
Yeah.
I mean, every old person, they're on Coumadin. It's kind of scary.
Like when they until they switch to that, what was it, the real soul and all
They're all,
that.
yeah.
And now it's a recall.
And then the one that my dad's on, when I was telling him he was eating, last time I saw him, he was eating a salad. I said, they were eating collard greens. They love them. And my mom had made some and some cornbread. I said, you're not supposed to be eating that. You're on Coumadin. And he turned around and politely told me he was on the new one and that he could eat whatever he wanted because it doesn't affect him anymore. So they twisted it around and figured out another way to stick it to me.
About diabetics, it just says some medications are blocked from being absorbed by products, by grapefruit juice, fatty meals, milk products. Yeah.
So that goes in and just blocks our receptors. Then the med can't get in. So. Alright, and then this is something I do want you to know. On page 43, at the top, it says MAO inhibitors, or MAOIs. Those are a class of drugs, or a category, that are very, very dangerous. It says, a very dangerous, potentially fatal interaction can occur with foods containing tyramine. Y'all see that on the top of 43 right there? Highlight tyramine because that comes up on your NCLEX. There's tons of, MAOIs are for like blood pressure, heart, all kind of, antidepressant. There's a lot of them that they use them for everything. But there's so many food interactions that they didn't know, and these people were on this med, and all of a sudden they come in having a stroke. And they were like, what is going on? And then after they traced it back and did some research, they figured out they had eaten cheese while they were on this, and it spiked their blood pressure, and they had a stroke. And so tyramine is it's a chemical they use, I think, for preservatives or something in, it's wine, like hard cheese. It's like a side product of,
It's in a lot.
yes. And so that's why so many people were dying from being on these MAOIs. Because it's in tons of everything, and you didn't know, and then you go to the grocery store and eat it, and you die. So know that one for sure, okay? Everybody hear that? MAOIs, you better know. Tyramine is the thing that's in it that triggers the reaction. So hard cheeses, chocolate, beef or chicken livers, sour cream, yogurt, raisins, bananas, avocados, and it's in everything.
Oh my God, I would be
Soy sauce, meat tenderizer, even like the little bouillon cubes and stuff. Okay? See the symptoms? Headache, nosebleed, chest pain, photosensitivity, severe hypertension, and then they'd have a hypertensive crisis or a stroke. They bleed out.
So on the intakes, will there be questions about
All of it.
specific meds?
Pharmacology is the weak spot that everybody does poorly on. Because it's just so much. So we're trying to zone you in on what you know they're going to ask about. Alright? So just know that about tyramine, because I know that was a big group. Alright. It's 100 degrees in here. Is everybody warm now so I can freeze you out? It's hot.
What's the river number? It is supposed to be like 15.
Alright, so let's get through chapter 7. We'll start on it. We'll probably do the math part tomorrow. Did anybody read chapter 7?
The mouth was hard.
The math part was a little bit difficult to me. So the math part, don't even worry about it, because this book doesn't teach you in dimensional analysis. So we're going to teach you that. But there was a lot of good information in here about, like, drawing up and the different kinds of syringes and stuff like that. So what I thought we'd do is just kind of talk about it, and then I'll bring the med card down here, and I'll show you all the different things, and you can see it later, okay? Maybe I'll bring one of the fake butts, and I'll just stick. You want a fake butt? Yeah, and the one that's in there's got that big nasty wound in it too. I'm like, I don't want that one.
That's why I said I don't want to be.
I don't want that one.
I want to
I want the jelly, but I don't want the squash and extra on the jelly.
You want the wet jello?
I wouldn't like a jelly, but I don't want to do the work for it. I don't like to do it.
Oh my God.
Alright. So, like I said, in chapter 7, it goes over the different kinds of math. Don't worry about the first two. I was taught ratio, proportion. There's lots of ways you can learn it. We're just going to do dimensional analysis. That's the way Dr. Little, who is our boss, does all your curriculum. She wants us to teach that.
Is it like desired BH times Q?
No, it kind of is. I've got some math practice ones we'll go over. So for now, we're not going to worry about it because we'll go over the math separately. We're going to do the lecture part of it, and then we'll do the math. All right? So I know if you did read it, it's confusing. That's why I asked you, so just disregard that part. All right, insulin. What does insulin do to our body? Anybody know? Anybody in here diabetic? Insulin lowers our blood sugar. Normally, if you're a healthy individual and everything And so, no matter what it is. And so, the body says, here's the pancreas releases some insulin, and let's say we ate 2 slices of pizza. That's a lot of bread, a lot of carbs. Our blood sugar is 600 something.
Wow.
That's okay because our pancreas works. So as soon as you eat that and it starts digesting, and all those little sugar cells, sugar is going out into your cells, the body releases insulin, it goes in, and it lowers your blood sugar down to a safe level, okay? Normally.
Not if you have time.
Now, if you're a diabetic, you either have a pancreas that never worked to begin with, so everything you eat makes your sugar go up, and there's nothing to pull you back down, so your sugar stays high. You're a diabetic. Or if you have, at one time, your pancreas worked, but now maybe it doesn't produce enough insulin. So your sugar goes up, you can produce a little insulin, but you're not back in the normal zone yet. You're not sky high, but you're not in normal range as a type 2 diabetic. So that's what insulin's for. Drops your blood sugar. The good thing about it is it keeps us in a normal range. The bad thing about it is it's a very sensitive thing. If you give too much, you can kill somebody. You hear me? You can kill somebody with an insulin shot. I had a friend who was a new nurse, and normally you give it in very, very small increments. She read the order wrong. It was supposed to be 6 units, which is a tiny, tiny amount. She gave 60 units. Killed them. Killed them. Because it dropped their blood sugar so low that they never could recuperate. Your brain needs glucose, and once the brain didn't get any glucose, it shut down and they died. So always, always be careful with your insulin, okay? You have to be very accurate, and most places require 2 nurses to check it off before you give it. Because of simple things. If she had to check that off, I would have been like, 60? We don't ever give 60. You know, what's their blood sugar? But she didn't. She just drew it up. She was in a hurry, and she went and gave it. So there's most places have a protocol that you have to check that off with another nurse. It was it was a medication error, and it was neglect, or
She lost her license.
no, she didn't lose her license. She had stipulations on it. It was a medication error, and she was a young nurse, and she had to go through court and had her license stipulated down to nothing. She had to stay with a nurse. She only had to work. She could only work where another RN was and stuff like that, and for years. And then she had to go through and do more classes and all kind of stuff. So, and then she ended up working in an office after that. She didn't work in a hospital anymore. Anyway, so just be careful. My point about that is insulin's very, very dangerous. Okay, small errors can make a big change in insulin dose. Okay, so we'll talk about it when we do our math, but we've got to be very, very careful with insulin. Always double check with somebody, and then use the correct syringe. Which insulin, you only have an insulin syringe. You cannot use any other kind of syringe for insulin because it's marked differently and measured differently than the ones that we give pain meds or antibiotics or flu shots out of, okay? Insulin has its own little syringe, and it's measured in units. And you should always recheck with another nurse, okay? Everybody got that about insulin? All right. In your book, if you haven't read, this is a really good chapter to start reading on, okay? Because it gives you a lot of, just skip over the math part and start on the, on page 74 where it starts with insulin. That's where you really should start reading, okay? Yeah, the bottom of 74, all right? So, there's different kinds of insulin too. You can have the regular one that's clear, and then you have some that are mixtures, and they're cloudy. So you'll hear somebody sometimes say, just draw clear before cloudy. And we'll talk about that further along, but know that there's different kinds of insulin, just like different kind of meds. The regular is rapid. So if their sugar was 800 and I needed to give them an insulin and make it come down quickly, I'm just going to give them the R. If I needed their sugar's high, but I need to give them a little bit of R now to pull them down, but I know that they're going to be eating a lot of carbs today, so I can give them the slow acting one too, right? And that way it carries them over through the rest of the day, so that if they eat and their sugar spikes, my slow acting one is right here to pull them back down in the normal range. Okay, there's lots of different kinds of insulin. Okay, IV flow rate. If you are in a hospital or a long-term care setting, sometimes we have pumps, but sometimes we run out of pumps. I worked during Hurricane Katrina, and there were no pumps to be found. And then we worked at the flu season one year. It was so bad, and everybody was coming into the ER, and we just had no pumps left. So we had to do it the old school way. We had to hang them up on a hook and calculate it and eyeball it with our watch and figure out how many drops literally were dropping into the chamber each minute. And that's how we figured out our flow rate. And so we'll show you how to do that with your math questions and stuff. But it's important to know because if you're given fluids, IV fluids, they can only go in at a certain rate per hour. Okay? So with somebody who is dehydrated, they're going to need a lot more. So they might have a little bit higher rate per hour of fluids going in to their IV. Right? So like 100 milliliters per hour, that might be their order. But if they're like elderly, they have a weak heart, or their kidneys aren't working good, do they need that same amount of fluid going in every hour? No, because what's going to happen to them? Too much. You're going to drown them, right? We're overloading them. So the rate depends on the person too, right? And the doctor will start out with a basic order, but you as the nurse, if you notice that this is hurting my patient, they're just wet, their lungs are, they can't get rid of this fluid, they're not peeing, and they're holding all this fluid in, I need to be the one that calls the doctor and say, hey, this IV rate is way too high, you need to lower it down, okay? And they'll tell you thanks, because they're not there putting their eyes on them, okay? So, like I said, you're going to make accommodations or modifications for elderly and infants. Infants are the same way. Their bodies are little. They don't need as much as us. And they have their own special set of IV tubing, and I'll show you how that is, okay? How that works. Okay. We already talked about Clark's rule. That's in your book. That is how we calculate, or the physician or the pharmacist calculates their medications based on body weight, the child's body weight. So that is again why getting a child's weight, a pediatric or an infant, is very, very important when they come in. If you're the nurse and you're the intake nurse and you're taking vital signs, weight should be one of your vital signs on a child, right? Because if we don't know how much they weigh, how much antibiotic are we going to give them? We don't know because we don't know how much they weigh, right? And then you're going to get the look from the doctor like, so always know to weigh a child because that's how their meds are based on. Okay, it's Clark's rule. Sometimes they'll use the body surface area of a child, but in general it's always based on weight. Okay, and your book goes into those different kinds of calculations. And then there's a nonogram. It's a chart that displays like the difference between the data so that they can calculate it based on height and weight. But just know, what I want you to know about that is if it's a pediatric, what do you need? Weight. You need to know that child's weight. Enteral meds, what did we say enteral was earlier? How's that getting into the body? Mouth. GI. And GI tract means from the mouth down to the anus. So anywhere along that track is enteral, okay? You can give meds. I don't want to say this because y'all have already been putting them. You can give meds anally. You can give them rectally, okay? If they are throwing up, so they have an upper GI virus, and they're throwing up, we can give them a suppository rectally, like Phenergan, that will absorb, because that's thin down there too, and it absorbs into the bloodstream, and it keeps them from vomiting, okay? If they're vomiting, I can't give them anything by mouth, because what's going to happen? Vomits right back up. So that's when we use suppositories, okay? So, there's lots of ways we can give meds enterally. It can be PO, through their PEG tube, like we talked about, their NG tube, or rectally. And then there's a page, on page 79, it shows all the different kinds. It can be capsules, elixirs, emulsions, the lozenges, suspension, syrups, tablets, all that, okay? There's lots of good ways we can do it. Alright, so if we're giving them orally, that's usually it. By mouth, like a tablet or a liquid. And we always want to be with asepsis. Have y'all learned asepsis yet? Yeah. A means without. So anytime you see the letter A in front of a word, that means without. So without germs. What we want to do is as clean as possible. You go in and you've already washed your hands good. You prepare the med and you give it to them. Now, what if I drop one on the floor? 5-second rule? No. We don't want to do that because we're putting it in their body, right? 5-second rule does not apply in a healthcare setting, ever, because you don't want to know what's going on the floor. Alright, so you always get it ready. You know, clean hands, a clean surface. It doesn't have to be sterile because the GI tract's not sterile, but we want it to be as clean as possible. And then, you know, you can open them up, dump them out, and we'll practice that in a little bit when I bring the cart down here. And then you give them meds. When you're giving them meds, what is the thing I need to check for? All my rights. Yeah, right dose, right route, right patient, right time. You know, make sure everything is done correctly. You don't want to be making an error. Okay? They can have solid or liquid, which is the pills or the liquids. And again, if it's solid or a liquid, we want to make sure they can swallow, right? If they're having trouble swallowing, let's say they were coughing all morning, or they feel like their throat's thick, or you notice their speech is slurred, do I want to give them their PO meds? Maybe not. Maybe I need to hold it and wait to make sure they can swallow. Something may be happening through the night. They may have a stroke. Had a stroke. Okay? When they have an NG tube, that's the tube that we can just put in and take out. It's temporary. And you can give that through their tube. What is the first thing I need to do, though, if I'm having to give them through the NG tube? Got everything prepared.
Make sure it's where it's supposed to be.
Right. I need to check for placement, meaning that the tube is in the stomach. Because it starts at the nose, goes into the nasal cavity, it runs down the back of their throat into their stomach. Okay? Sometimes it can come loose, or they didn't put it in correctly to begin with. It could be down in their windpipe. Surely someone would have noticed by them, but you'd be surprised.
How do you know where it actually?
When you put it in, you'll see, you take a big syringe and you aspirate back and you'll see stomach contents, that stomach acid. If you're in the lung, you shouldn't see fluid, right? So you'll always check for placement. You can push air in and listen and you'll hear bubbling, and y'all will do that in the skills lab. But always make sure that you're doing checking placement before you put their meds in. Because one, you don't want to waste your meds, and two, if it's going in their lungs, you just cause them to get pneumonia. Right? Okay? And same with a PEG tube, the one that's permanently coming out of their belly. Always check the placement. You can aspirate back and make sure that you've got stomach contents. Because those can wiggle out too. And they look like they're in there, but they're not even in the stomach anymore. They're just in the layer. Yeah. And so you always pull back and check placement and make sure you've got stomach contents before you give them in. Okay? You can give some pills crushed, some you can't, and you'll know because it'll tell you on the packaging that some are not meant to be crushed. They're meant to be released slowly. They have that enteric coating on them, that real thick coating, and it's meant to last a long time. So always make sure if you're crushing pills to mix with water or pudding or applesauce to give to those patients, that they're the kind that can be crushed. Okay? Capsules, some shouldn't be, most of the time. The ones that open up look like little tiny gumballs, those usually aren't supposed to be opened and crushed like that. So if that's what's ordered, you have to call and say, hey, this is only a capsule, I need you to come out with something else, because I can't put these in the tube. They'll clog your tubes up. Okay, so here's your thing about the NGs. You're going to aspirate stomach contents, then you're going to push that back in. You don't want to get rid of it, because that's stuff they need. They have all their electrolytes. So you push that back in, and when you push it, you listen for gurgling sounds. You can also listen to their lung sounds to make sure that they're not wet. You know, they don't sound like they've got a lot of congestion. And then you put the medication in the tube, and usually we pour it, if it's a PEG, we pour it by gravity, just like a funnel. You let it go in by gravity. You don't ever push that. But if it's an NG tube, you can slowly push it because it's just temporary. Okay? And then we always flush with some water afterwards. Has anybody ever seen any meds given through a PEG tube? Yeah. You should be doing a flush before and a flush after. And you're thinking, my God, they're not going to be able to hold all that, but they do. They hold all that fluid. To flush it through and get the diffusion going, right? I need a little water to make sure what I'm putting in their system is going to diffuse and get into their system. So we add water and flush. All right, everybody's favorite. Rectal suppositories. When you're going to need to put this in, you have to position your patient in a certain way. Does anybody know what it is? Which side? Left side, or Sims. It's called Sims position. The same one when you're giving an enema. And the reason for that is your anatomy. Okay. So on our colon. So I'll just start.
Have you ever seen the whole rectum come out?
Yeah. I have. It's awful.
They have to push it in.
Yeah, it's awful. So first colon, the descending colon, and then the rectum where the exit door, okay? So that's on your left side. So that's why we position our patient on the left side so that when we insert the medication, it stays there. If we had them on the right side, it's going to come out. So we want to always come on the left side, and it shows you in the book how to, gently put them on their side and turn them. They've got them on the right side, but it should be left. You can see on the bottom one, they've got them on the left. And you can pull one leg up for them to brace them, and then you just prepare them. Okay, it's going to be a little pressure, and hopefully you've got some kind of lubricant, and if you're, a decent person, and you're gently inserting. Some people you want to, but you can't. You gently insert with a little bit of lubricant, okay? So make sure that you're doing that, and explaining the procedure to them. Now, these little elderly that are confused, they don't like that business. They do not like that at all, and they will swat at you or claw at you. So again, reorient, prepare them, explain it to them, because they don't want anybody messing in that neighborhood down there. Okay? And then, make sure you clean them up good. You don't want to leave them with any. Sometimes they might have a little bit of residual stool there. You want to clean them up, cover them up. Maintain professionalism and dignity. Don't want to leave them like that. Okay. When you're giving shots, y'all should probably know this from just the way our culture is now. We're all very scared of a needle stick, right? So we always are going to be following procedures and standards that our facility teaches us about. But as a general rule, you should have your gloves on, because if you give a shot, an IM injection or IV, there's a chance of blood to come out, right? So you're wearing your gloves to protect you. It's going to be a really messy one, like maybe a larger vessel, double glove, okay? And then after you give the injection, you're not going to just lay the used needle down, because what could happen? Yeah, you could get stuck, or they could get stuck, and then they're going to, be upset. So you take it, and I always carried mine up like that. That way, if there was any kids running around in the room, grandkids, people who wanted to help but were really in your way, you're not going to stick them. You just walk like that, and where do I put that used needle? Sharps container, the red biohazard box, okay? And you put it in. Now, easily, because what could happen, sometimes if they're full or the little flap door doesn't work right, it can pop back on you and stick you to your glove. So just put it in, gently do that. It's very easy to get in a fast habit of just throwing it in there, but I've seen them pop back out and hurt people. So just be careful the whole way through the process, because nobody wants a needle stick. Okay? Have you ever been stick? I haven't, but I did have a friend, and the patient had hepatitis, and so she had to go through a lot of series of tests and stuff for a long time afterwards, every 6 months or whatever, to make sure she wouldn't get sick. It's easy to do. Okay, and then parental needs into the skin. We're going to be given that, and there's different kinds of routes. It's on page 87 in your book. You can do sub-Q, which is where we pinch up the fat and give it, and then IV, IM, yeah, it's all on here in your book. And these are for people, again, if they can't take something orally, or the med can't be given orally. It's something that is not ordered that way, or it would upset their stomach. We can give it in their muscle, and eventually it will be absorbed into the body, okay? Now, here's this thing about the medication might be removed from the body on the first pass. We were talking about that earlier. Through the liver, before it can get into the tissues where the body will know what to do with it, okay? So sometimes it takes an extra dose to get them started. What would you think the advantages of giving an IM or a parental injection are? Yeah, what are some of the good things about it? It goes into the bloodstream straight if it's IV, so it's quick. If it's IM, less risk for it being broken down, right, by all the stomach acid and then the time it takes to digest. It's getting here and it gets picked up quickly. But some of the disadvantages would be what? Yeah, pain, they're more expensive, risk of injury to you and the patient, right? And sometimes, people get tired of being stuck, right? And sometimes it can eventually cause tissue damage underneath, especially if you're doing insulin injections. that's why we tell our diabetics to rotate their sites, because those cells, just like our little cells, they're full already. They're like, I don't need any more. Quit sticking me here. I'm full, and they don't absorb anymore. Okay, so you have to rotate your sites. It can cause a little breakdown under the skin and cause a little skin ulcer there. Alright, so then there's different types of syringes, and I'm going to bring those down here for you so you can see them and play with them. Y'all see that one that's on page 88 that says figure 7.6, the parts of the syringe? So you got the tip, where the needle will screw on, and then some have already have the needle built on. Some don't. They come with just the syringe, so you can screw the needle on. And then you've got the barrel, where the medicine's actually going to be held, and then the plunger, which is what we push to push that into the system, in the body. Okay? And then you can see the difference in the needles or the syringes at the bottom. See how it's calibrated differently or measured differently? That one on the far left is just a 3 milliliter syringe, but then the one in the middle is, look, it says U100. That's 100 units. That's the insulin dose, the syringe. And so look, 10 units of insulin is like not even half a cc, or you know what I mean? They just measure out a lot different. So it's always very crucial to look at your syringes. Okay. And then the lengths of the needles and the diameter can be different too. Would I want to use a 26 gauge needle on a 300-pound big man? No. Why not? It's shorter because it's only 3/8 to a half an inch, so it's not even going to get through his skin, is it? And then a 26 gauge is tiny, tiny, tiny. So who would that needle be more appropriate for? A baby, a child, somebody that's very, very fragile, right? Little, yeah, less bone. I mean, meat. You know, they're just skin and bones. Very emaciated. All right, and then look at the other one, though. 15 gauge. Look how thick that joker is.
It's a real thick.
Why would I need a needle that looks like that going into a body?
Do that.
Spinal?
Isn't that what they use for
You can get the
upper
stomach
bones?
to because
Like,
of it.
when you donate plasma?
Really thick products going through. So if it's blood or blood products that we're trying to give or take out, you know, you don't want to hemolyze or break down those cells, so they get a big, just like a water hose. The bigger the hose, the better the stuff goes in and out. And then what about thick medicines? There's some meds that are real oil-based and thick, and they're harder to push through. So you need a bigger, thicker needle, okay? And so I'll bring some different ones so y'all can literally open them up and see the difference. You don't want to give a baby anything with a 15 gauge needle. You'll leave a chunk of skin and tissue out of their leg. Okay? So always use the appropriate size and length and diameter, because we don't want to hurt them. We don't want them to just get in and out. So I'll bring some of those and y'all can look at those. And then when you have an IV, it's kind of the same way. If you're putting a lot of fluid in fast, you want a big needle. You have a bigger, thicker water hose. The more I can get in quicker in an emergency, right? So I want a big needle, an 18 gauge, a 16 gauge. And then if it's something that doesn't have to be right away, I can use a smaller needle. If it's something that's not an emergency. And then for volume of meds, they come in milliliters. Y'all know that, milliliters and cc's. You remember that from your conversion chart I gave you? Yes. Okay. We talked about the needles, and there's some specialized ones. We'll show you those. And then how to determine where to give an injection. And you'll go over this in the skills lab more in depth, but since it's in our book, we'll just kind of look at it real quick. Oh, look on page 94. Do you see that? It says A. That's the old Carpuject. That's what Betty was using. She took this, see how in picture B, he's got that little tube of medication, and he's putting it down in the Carpuject. And then once you lay it in there, you screw it in from the bottom, and then you can inject it. Well, at the bottom is where the cork with the screw was. That's what she was unscrewing and taking out the Demerol. And then she would put saline back in it, screw that back on, and then give it to the patient. So that's probably why I don't use those anymore. That's how old this is. But there's the old Carpuject. You may still see those in some long-term care places. They are. They've been there and done that. And then you can see on page 95, the little volume control chamber, that picture on the left of the, looks like it says glass bottle, like IV fluids, and then it has the little volume control chamber. That's what you would use on children. So what's going in, I fill up my chamber first, and then I clamp off the top part between the glass bottle and the volume control chamber. I clamp that off. So now, instead of having a whole bottle being at risk of going in, I only can get 200 cc's in at a time. It makes you go back and check on that IV every 200 cc's. And the reason for that is like somebody who's got really fragile veins or a child, they can blow real quick on their vein and then you can have an infiltrated vessel. And so we use that type tubing for those types of situations. Okay? So just know those are out there. Alright, and then on page 96 it shows you different places that are sub-Q that you could put sub-Q shots in, injections. And then IM, here on page 99, what's this muscle called? Who's my workout guy? You're the trainer, right? What's this one called? Deltoid. Deltoid. And you have them on both sides, I hope. Mine are not very developed, so can't use mine. But come up here, let's see your good deltoid so you can visualize it. Do you care? Show your deltoid. He's got a flex. Look, he's struggling. Hold on. So what you do is on your patient, you always look for what type of body style they are. If they have a lot of muscle, it's going to be easy. I can tell right away. I'm not going to have any trouble giving a shot right here, right? But what if it was my 90-year-old little grandma who had no muscle? I'm going to have to find a different spot, right? So what you do is you find your landmarks. You'll find their top of their bony clavicle, where it comes up out here. You'll feel it. You can feel for your own. And then you just find your landmarks, and you know that that's where the deltoid is. And sometimes you can see it come down to a point, and that's where you know you're going to go in and get that IM.
She finally has a male student that has a deltoid.
Yeah, we had more deltoids than some.
I have more deltoids than.
So in a child, it's not going to be as big, right? Yeah. An adult, it's going to be larger. So I would feel safe giving a larger amount of dose in his deltoid than I would in my frail little tiny muscle of my 9-year-old grandmother, right? Okay, so then there's other places you can look on that book, and I'll be right back. For the IMs on the next couple of pages. You can do it in their hip. Showing in their hip. Child and adult. I'll be right back.
Go get my phone, Dad. No, I said 10 years. 8. Martha, you better get my phone. Girl, man. Oh.
child in their hip on the bottom. That's the dorsogluteal. And then look at the child. You can give quads. How many have had their kids have to get shots in the leg? Why do we do it in the leg in infants? That's really their largest group right there. When they're babies, they don't really have.
I just thought it was they can hold them down like that.
You have to be real careful when you're doing it in the hip because you can hit that nerve and then like they come in 3 days later and like I can't even walk. So you have to be real careful with the placement. Yeah, the rest of them So let's take a break and I'll go get some stuff that y'all can practice with and look at and just see the difference. But any questions on any of this? Like I said, this is a lot of what you're going to have to do in the skills lab. I did want to mention to you that for the topical though, some stuff, if it absorbs through your patient's skin, is it going to absorb through your skin?
Yes.
Right. So that's why we always wear our gloves when we put on topical. There's nitroglycerin paste. Nitroglycerin dilates and opens you up for chest pain, and if you put that stuff on without your gloves, it gets into your skin fast, and you have a frontal headache to the bottom of yourself, not the bottom of your liver. So always wear gloves if you're putting on a cream on a patient, okay? Because if it's going to absorb through their skin, it will absorb through yours. So you need to wear gloves, okay? And then it just kind of talks about the eye drops, the ear drops. For a kid, you might want to know this on page 116. When you're giving ear drops, the way you can kids, you have to look at it, hold down and back. Down and back for a kid. And then when you're an adult, you grow up, you have to pull up. And the reason is because the way their skull isn't formed yet with your child, and as we grow, it all stretches out. So that's why we have to pull it different directions. Yes, it's on page 116. Alright, and then for eye drops, we know there's one eye drop. Put the eyelid in there, kind of doesn't let it absorb. Isn't that neat that it can absorb through your eye? Like yeah, and then you put it up there to block that lacrimal duct so that it stays in there, doesn't drain out their nose. Well, it does. And they're never standing that still. They're always kicking and screaming at you. And then you can see there's a good way to check to see if your inhalers, how many of y'all have kids with inhalers? Do you ever check to see if it's empty or not? You see how it's floating? If it's empty, it'll show it floats. So you can teach that to your family members. So this is all real good info on page 116, 117, okay? And then there's vaginal. We can put, believe it or not, we can put stuff, yeah, vaginally. And then get cream for that. So there you go. Every orifice you can put medicine in. Cream, there's lots of cream. So y'all take a break. I'm going to go get you some toys to play with to see the difference in the syringe and needle.
Medical toys, Martha.